Hello, this talk will be on emergency head and neck infections, and I have no relevant disclosures. What I will cover during this talk are a variety of infections involving the neck and also skull base infections that you may see in the middle of the night. So this is a patient that presents with a left-sided neck mass. And one thing when we have a patient that's presenting with neck mass is oftentimes these are due to enlarged lymph nodes. So the first thing that we have to do is to get our definitions correct. So both of these patients have masses involving the left side of the neck. Notice how the patient on the left has a solid mass and the patient has a right has multiple enlarged lymph nodes that have low attenuation areas within these. So both of these are enlarged lymph nodes, but one has areas of low attenuation. Now, the patient on the left has cervical adenitis, which is a painful and enlarged lymph node that's solid. But on the other hand, if you see a lymph node that contains areas of low attenuation, then the proper terminology is suppurative adenitis. And we're going to be coming back to this term suppurative adenitis through the course of this lecture. So this is an example of two patients that have enlarged lymph nodes. So this is a patient that has a mass on the left, and this would be cervical adenitis, since this is a patient that has a painful enlarged lymph node. This, on the other hand, is a patient that has also a painful enlarged lymph node, but that has low attenuation in it. So this was technically suppurative adenitis. Now, there are a variety of causes that could result in this type of imaging findings. But on the other hand, if you had a child that presents with a cat, then this is a classical example of cat scratch disease. Now, cat scratch disease is a common cause of enlarged cervical lymph nodes in children. It's due to this organism called Bartonella henselae, and the bacteria is also present in the cat saliva. Now, one thing about cat scratch disease is that you don't necessarily need to have a cat scratch someone. Oftentimes what will happen is that the cat, this Bartonella henselae, which is in the cat saliva, can be transferred to the paws. And then the paws can either be eventually transferred through a scratch, or the patient may actually have an open wound and the cat may actually end up licking that open wound. So if you do have patients that present with enlarged cervical lymph nodes, think of cat scratch disease. Now, these usually present as epitrochlear lymph nodes, oftentimes because there's a little cut on the hand, and the primary echelon drainages of those epitrochlear lymph nodes, of the hand, goes to the epitrochlear lymph nodes. So basically what this is a common drainage. So if someone does have a cut involving their neck or gets scratched the neck, then oftentimes this is the cause of cat scratch disease, because this in a way is a primary echelon drainage. And that's why cat scratch disease involves the nodes involving the head and neck. Now, this is another example on the central area here. This would be properly described as cervical adenitis. And on the right-hand side, this was a patient that I saw many years ago when I was at University of North Carolina, probably about 25 years ago. And I saw this patient in head and neck tumor conference, and I very elegantly described this as a metastatic level 2 lymph node. Now, they biopsied this, and there was no tumor that was found. And I was a little bit perplexed. But then on the other hand, if you have ever traveled to India or South America, you may be familiar with something that looks like this. This is actually tuberculosis, and this turned out to be scrofula. This is tuberculosis involved in the neck. And in this case, on the right-hand side, they ended up placing a PPD, and it was PPD positive. So this was actually tuberculous adenitis. So, you know, there's an old saying that good judgment comes from experience and experience comes from bad judgment. This is one of the things that I learned in my journey. So just realize that tuberculosis is the great mimicker. Scrofula is tuberculosis involved in the neck. And in the head and neck, it usually involves the lymph nodes, but it can involve other head and neck lesions. And when the biopsy is performed, tuberculosis typically is characterized by granulomatous inflammation and caseation necrosis. And this is the more common appearance of tuberculosis that you're probably used to seeing. This is Pott's disease. So this is an example of relative preservation of the spine. We can see that despite all of this destruction, the spine is relatively well maintained. And they have this anterior involvement of the spine. This, when I grew up, was called coal abscesses. as I've sort of gone on with my journey, I think this probably represents suppurative adenitis involving the retropharyngeal lymph nodes. We used to call these cold abscesses, but I think this is probably abscess involving the retropharyngeal lymph nodes. But this is the more classic appearance of tuberculosis of the spine, which we refer to as Pott's disease. Now, this is sort of everyone's nightmare. Some child, you're in the doing the ER shift, and a child presents with an increased soft tissue involving the prevertebral space. So if the patient has a stable airway and you perform a CT scan, in this particular case, we can see this well-defined fluid collection that's paramidline. And if you look real closely, we can see some edema here involving the retropharyngeal space. So when we look at the anatomy in this area, we have this fascial layer here, which is referred to as the visceral fascia. Sometimes it's also called the pharyngomucosal fascia. And I will say about the fascia, there was a French author in the 1800s, Malgagny, who said the name of the fascia changes with everyone who writes about it. I'm paraphrasing him. But the point is that the names of the fascial layer have evolved even over my lifetime. I use the terminology that was proposed by Grudinsky and Holyoake in the 1930s, which is the visceral fascia, which encompasses the prevertebral space. Some people may use the pharyngomucosal fascia or the pharyngobasilar fascia, again, identifying the pharynx. So whatever you choose is completely fine. Now, behind this fascial layer is this dashed line, which is referred to as the alar fascia, and the space between the visceral fascia and the alar fascia is the true retropharyngeal space. Now, the space between the alar fascia and the prevertebral fascia is referred to as the danger space. So this area, the true retropharyngeal space, which is located between the visceral fascia and the alar fascia, contains these lymph nodes. Now, these are the retropharyngeal lymph nodes, are also known as the nodes of Rouvier, so you may hear that term as well too. But the point is that we talked about suppurative adenitis. And if you see a well-defined fluid collection that's paramidline, then the proper diagnosis is actually suppurative adenitis involving the retropharyngeal lymph nodes. Now, the reason why that's important is that if the surgeons went in and they drain this retropharyngeal lymph node, they may get 1 or 2 cc's of pus. But it's not a true retropharyngeal space abscess, because when this retropharyngeal lymph node becomes inflamed, it can result in effusion involving the retropharyngeal space. Now, this type of appearance and this pattern recognition is now well recognized by the ENT surgeons. And if you do have this pattern recognition and you correctly identify it's suppurative adenitis and the patient does have a stable airway, then they can be treated with broad spectrum antibiotics and do very well. This is another example of edema involving the retropharyngeal space. And with the leap of faith, if you look at this, you can see this little line right here, and that line represents the alar fascia. So this is an example of retropharyngeal space edema. And you can see in this particular case, these yellow arrows point to this dashed line, and that is preservation of the alar fascia. Now, sometimes you actually can have hyperemia. You can see small vessels here, again, approximating the location of the alar fascia. And if you can see that, that is just retropharyngeal space edema. So retropharyngeal space edema is characterized by symmetric low attenuation in the retropharyngeal space. It has variable mass effect, and it does not have the enhancing wall. Now, this was a patient that presented with neck pain. And when you look at the non-contrast CT, similar to what we saw before, we could see edema involving the retropharyngeal space. Now, this patient was afebrile, but did have retropharyngeal space edema. And then when you look at the soft tissue windows overlying the anterior aspect of the dens, we can see this ossific density here. And what this represents is calcific tendinitis. So calcific tendinitis is a non-infectious inflammatory process that results in retropharyngeal space edema. It's typically due to calcium hydroxyapatite deposition in the longus colli muscle. So I kind of refer to this as gout of the neck. The etiology is unknown, and it's typically treated just with non-steroidals. Now, this is the sagittal images of the same patient demonstrating C1, C2, and this small little ossification here, which is the calcium hydroxyapatite deposition. And because of the surrounding inflammation, results in edema involving the retropharyngeal space. Another example here, we can see edema involving the retropharyngeal space. You can see it's expanding the retropharyngeal space. Anytime you look at this, make sure you look very closely and make sure you reconstruct everything in bone algorithms, because when you do, again, you'll be able to see, again, calcium hydroxyapatite deposition approximating the location of the longus colli muscle. And again, another example of calcific tendinitis. And another example here, this was edema involving the retropharyngeal space. We can see the alar fascia, and again, just anterior to C1, another example of calcific tendinitis resulting in retropharyngeal space edema. So when you do see this, you don't want to mistake this as a retropharyngeal space abscess. Now, let us discuss true retropharyngeal space infections. So we talked earlier about suppurative adenitis, and this is suppurative adenitis involving the bilateral retropharyngeal lymph nodes. If this suppurative adenitis continues to progress, it can essentially extend and literally pop into the retropharyngeal space, resulting in a true retropharyngeal space abscess. And if you look closely here, you can see small little pockets of air. Now, this aggressive inflammatory process is anterior to the C1, C2 vertebral bodies. And if this is untreated, this infection can progressively erode through C1, C2 and extend into the spinal canal. So this is indicative of phlegmon, and if you give contrast, what you can actually see is peripheral enhancement. So this is an example of a retropharyngeal space abscess extending posteriorly through C1, C2, and then extending into the spinal canal, resulting in an epidural abscess. And this is the natural progression of untreated retropharyngeal space infections. Now, this is a true retropharyngeal space abscess. So what we see is a large fluid collection that's centered in the retropharyngeal space. Now, oftentimes these retropharyngeal space abscesses are symmetric, but in this particular case, we can see it's asymmetric and is extending into the lateral portion of the neck. Now, one thing about retropharyngeal space abscesses, unlike other areas of the body, is that the enhancement around the wall of this abscess is very variable. In fact, in my experience, true retropharyngeal space abscesses with the fluid don't really have enhancement. And that's unlike what you see in other parts of the body, such as brain abscess or hepatic abscesses, so on and so forth. Now, when you do see something that looks like this, this is a true retropharyngeal space abscess, and this does need to be treated with surgery, and the treatment obviously is surgical drainage. Another example here, another example of a retropharyngeal space abscess. Unfortunately, this was a patient that was eating something. This was a little prong from a plastic fork that pierced the posterior pharyngeal wall. Here we can see this fluid extending into the retropharyngeal space, and we can actually see multiple air pockets. So retropharyngeal space abscess can occasionally have air, especially if there's a communication with the adjacent pharynx, as occurred here with this little prong piercing the posterior pharyngeal wall. And this was another example of a retropharyngeal space abscess. This patient had an NG tube placed in the field. This patient was intubated in the field. They had trouble passing the NG tube, and unfortunately, this perforated the lateral pharyngeal wall. And so in this particular case, it was drained, and this is the example of the pus that ends up flowing through when a retropharyngeal space abscess is drained. Now, one thing we have to remember about retropharyngeal space abscesses is that these abscesses can extend inferiorly. So earlier, I went over the normal anatomy of this area. So we have our visceral fascia here, we have our alar fascia here, and between the visceral fascia and the alar fascia is the true retropharyngeal space, and this contains the retropharyngeal lymph nodes. Now, on the sagittal images, the purple right here depicts the location of the true retropharyngeal space. And we can see the retropharyngeal space extends inferiorly into the upper mediastinum and terminates at approximately between T2 and T6. On the other hand, this space that's located between the alar fascia and the prevertebral fascia is referred to as the true danger space. And this danger space on the left is depicted here in orange, and this danger space extends all the way from the skull base through the neck, through the mediastinum, and it actually extends all the way through the crura, and it goes through the diaphragm and is continuous with the retroperitoneum. But the bottom line is that anytime that you have an infection extending in this region, it can extend inferiorly along the fascial planes. And this was a patient that had a retropharyngeal space abscess. And then when you look inferiorly, this abscess extended inferiorly and involved the mediastinum. So remember, anytime that you have an abscess involving the neck, remember these potential routes of spread inferiorly. So you always want to extend your imaging and specifically look at the mediastinum and the upper chest to make sure that there's no inferior extent of that abscess. Now, this is another type of infection that can involve the oropharynx, and this is referred to as either a tonsillar or a peritonsillar abscess. I've seen both of these terms used. So when we look at the anatomy of the tonsil, we have this area right here, which is referred to as the palatine or the fascial tonsil. There's another component of the tonsil here, which is the anterior tonsillar pillar, and a posterior portion of the tonsil, which is the posterior tonsillar pillar. The majority of these tonsillar abscesses arise here in the palatine or / the fascial tonsil. Now, again, it's debatable. Some people will use the term peritonsillar abscess. Some people will use the term tonsillar abscess. In a true peritonsillar abscess, the abscess is felt to be due lateral to the tonsillar capsule and bounded laterally by the superior constrictor muscle. So right here at the tip of my arrow is where a true peritonsillar abscess should occur. Now, this is an example of a tonsillar abscess that ended up being drained. And here we can see that air within the drained capsular, the drained capsule, resulting in evacuation of that fluid. Now, this is an example of a patient that comes in with neck infection. So these are two neck infections. Now, this fluid here, this is a tonsillar / peritonsillar abscess, but in this particular case, this fluid collection is located lateral to the tonsil and actually located in this space right here, which is the parapharyngeal space. So on the top, this is an abscess that's involved the visceral space in the tonsil, and this abscess is involving the parapharyngeal space. So why is it important to properly identify where this fluid collection is? And that is because a peritonsillar abscess can be drained through an intraoral approach, whereas a parapharyngeal space abscess, as is seen here, has to require a cervical approach. So this is where you really, if you will, add value, because not only do you identify that there is an abscess in both of these patients, but in this particular case, it's located within the tonsil. And in this particular case, it's located in the parapharyngeal space. And that specifically changes how these patients are treated. Now, one of the complications of having a peritonsillar or tonsillar abscess is development of Lemire's syndrome. So Lemire's syndrome is a severe illness that was initially described as caused by Fusobacteria necrophorum. And this was described many years ago by Lemire. Now, Lemire's original 6 groups were based on the source, and one of the sources was the pharynx. So currently, we think of Lemire's syndrome as a complication of a severe pharyngeal infection that's associated with septic thrombophlebitis. So here we can see occlusion of the right internal jugular vein, and it's also associated with septic emboli that may involve the lungs or the bone. So this is the classical appearance of Lemire's syndrome. But realize when Lemire described this long before the days of CT and MR, you can see similar findings in patients that have infections involving the pharynx, the oral cavity, the middle ear or mastoid, the postpartum endometritis, and also appendicitis. Now, the one nice thing about Lemire syndrome, it has a good prognosis. So for those of you residents that are taking the boards, this is one of those things that it may show up, and certainly this oftentimes shows up on film panels as well. Now, you can have other causes of infections involving the oral cavity and the oropharynx, and a lot of it is just based on the normal spread patterns of infections involving the oral cavity and the oropharynx. So we talked about Lemire syndrome involving the tonsil and the parapharyngeal space. Now we can talk about infections involving the oral cavity. And the majority of these are odontogenic infections. So if you have an odontogenic infection involving the mandible and it extends anteriorly, well, this ends up eroding the buccal cortex. And here you can see this patient ended up having a submandibular space abscess because there was erosion of the buccal cortex. Now, this type of spread pattern was beautifully illustrated years ago by Laskin in one of the classic works. I think it was written in the 1960s. Like I said, I like to read the old literature because for me, it really helps me understand the concepts. So this patient ended up having osteonecrosis involving, an infection involving the anterior portion of the mandible. And because that buccal cortex was eroded, that's how he developed this submandibular space abscess. Now, on the other hand, if you have an infection involving the mandible and there's erosion of the inner cortex, the lingual cortex, then this can give you the classic sublingual space abscess. So this was a patient that had a sublingual space abscess. And when we look at the bone right here, we can see this bone is very irregular. And this patient had chronic osteomyelitis. And the common infection that's associated with chronic osteomyelitis is actinomycosis. So in this particular case, this chronic infection ended up extending into the sublingual space, giving you a sublingual space abscess. Another example here, a very subtle sublingual space abscess. Remember, please reconstruct these with bone algorithms, not bone windows, but bone algorithms. And when you do this, you'll be able to see a small little cortical break right here. So here's a small little area of osteomyelitis involving the mandible. And because the break here is on the lingual cortex, this results in a sublingual space abscess. Now, when we look at the anatomy of the floor of the mouth, what we've done so far is talk about the mandible, and we talk about infections that spread laterally and infections that spread medially. Now, one of the applied areas of anatomy that we have to remember is this very tough muscle right here, which is the mylohyoid muscle. And this muscle attaches to the myloid line of the mandible. This mylohyoid muscle is a very tight muscle, and it is the sling, if you will, of the floor of the mouth. And because of this tough muscle, what it does is it can prevent infections from extending inferiorly below the mylohyoid muscle into the sublingual space. So that's a good thing. But the bad thing is that because this muscle is so tough, what it can do in very severe infections is redirect this infection to be localized within the floor of the mouth. And if that happens and you have a very bad infection, this can result in swelling of the tongue, and it can also result in edema involving the larynx and specifically the epiglottis. And when you have this type of severe infection that essentially results in a strangulation feeling, then this is what was initially described by Wilhelm Friedrich von Ludwig as Ludwig's angina. So what Ludwig's angina is a diffuse bacterial infection of the floor of the mouth, which is usually odontogenic. It may be cellulitis, or it could be multiple abscesses. So this is an example of Ludwig's angina. In this case, we can see multiple areas of abscesses involving the floor of the mouth. So this is essentially a compartment syndrome involving the floor of the mouth, and this would be drained. This, on the other hand, was also clinically Ludwig's angina. Here we can see diffuse enlargement and cellulitis involving the floor of the mouth. And the end game is the same. Again, this results in diffuse inflammation of the floor of the mouth. This can result in that strangulation feeling. And again, but this is not treated with drainage, but rather this is treated with very aggressive IV antibiotics. In this particular case on the left, I also want to point out the diffuse inflammation involving the epiglottis. So when Ludwig actually described this, angina means strangulation. And you know, based on what I've read, it was actually Ludwig that first used the term angina to describe strangulation. Another example here, a patient with Ludwig's angina demonstrating edema involving the left area-epiglottic fold. And again, that's what causes that airway obstruction. And the treatment is typically basically just a floor mouth incision. And in this case, the middle here, they would literally have to take either, in this case, a finger or clamps and try to remove these septations and drain those multiple abscesses involving the floor of the mouth. So other things that you may see come through the emergency room are various soft tissues infections. So when we talk about infections involving the soft tissues, how do we define these? Well, erysipelas is basically just an infection of the superficial layer of the skin, and obviously we tend not to image these. Now, a cellulitis is an infection of the subcutaneous tissues. A myositis is involvement of the muscles, and then necrotizing fasciitis is destruction of the fascia. So let's take a look at these, and so we can separate what these look like. So this was an interesting case that came through the emergency room. I remember I looked at this and I said, there's this diffuse inflammation right here involving the posterior portion of the neck. And we can see there's skin thickening, there's thickening of the linear soft tissues here involved in the neck, this posterior paraspinal musculature. And I remember I called up the surgeon and I said, there's a lot of cellulitis going on here. And it turns out, he said, well, this patient did have a tarantula bite. So basically all of this cellulitis was due to a tarantula bite. So just a nice classical example of a cellulitis. And this was another patient that ended up coming through the emergency room. And this patient recently had a wisdom tooth removal. So this patient had bilateral wisdom teeth removed. And unfortunately, the patient was developing an infection and swelling of the jaw. And what we see here is not only does the patient have asymmetrical enlargement of the left masseter muscle, but this patient actually has fluid involved in the left masseter muscle and a little bit of air. So not only was this a myositis, but this was a myositis with a abscess involving the left masseter muscle. And this was another patient that came through the emergency room. This was a patient that has necrotizing fasciitis. So unfortunately, a clinical example of what necrotizing fasciitis actually looks like. So this is destruction of the fascia, but it also, because it's so severe, results in this case, skin destruction. So the characteristic findings that you see is diffuse air involving the soft tissue. So if you have someone that's never had surgery or never had radiation or chemotherapy or hasn't had coughing spells, has a severe infection, and you see all of this air extending along the soft tissues, those are the imaging findings that we expect to see in necrotizing fasciitis. So necrotizing fasciitis is occasionally it'll pop up in the New York Times. Flesh-eating bacteria is the other term. So this is an aggressive soft tissue infection that's typically caused by group A strep. The majority of the patients are immunocompromised, and there's rapid progression that may lead to airway obstruction. And here we can see this really severe form of necrotizing fasciitis involving the anterior neck, in this case involving the tongue. And you can easily see how this can result in airway compression. The treatment is usually IV antibiotics and surgical treatment as necessary. As I mentioned before, we can make the diagnosis if we see air involving the soft tissues. Now, this was a patient that clinically had necrotizing fasciitis. So with a leap of faith, we can see diffuse enlargement of the masseter muscle. And if you look at the parotid gland, the parotid looks like it has some increased attenuation. And we can see all of the cellulitis involving the soft tissues overlying the mandible. Now, clinically, this patient had necrotizing fasciitis, but quite frankly, we can't call it. But unfortunately, this patient went on to develop progression of this disease, and this was obviously severe myositis and abscesses, and all of this air confirms that allows us to make this diagnosis of necrotizing fasciitis. So let's move our attention now to skull base infections. So one thing that I want to point out is that when you are looking at any type of brain MR or brain CT, whether it's an outpatient, an inpatient, or the emergency room, what I want you to always concentrate on is always look for these unilateral effusions. So oftentimes they're benign, but on the other hand, if you do see a unilateral effusion, especially in elderly patients, unfortunately like myself, realize that the eustachian tube allows aeration of the middle ear cavity, and the middle ear cavity communicates with the mastoid air cells. So if you see a unilateral effusion, that oftentimes indicates some type of eustachian tube dysfunction. So remember, the eustachian tube extends anteriorly and it's located just anterior to the Torus tubarius. So the Torus tubarius is here. This is the fossa of Rosenmuller, and the opening the eustachian tube is going to be just anterior to this. So anytime that you have a unilateral infusion involving the mastoid air cells, please pay close attention to the fossa of Rosenmuller, because masses that involve the fossa of Rosenmuller can anteriorly displace the Torus tubarius and occlude the eustachian tube. So specifically what we're looking for are unilateral nasopharyngeal carcinomas. And remember, there are lots of causes for headaches, but one of the causes for headaches is mastoid effusions due to occult nasopharyngeal carcinoma. So one of those little checkpoints is always mention this in your dictation if you see it, and then make sure your eye looks at the fossa of Rosenmuller. Now, what I showed before was a unilateral effusion. Now, if this unilateral effusion starts to progress and it results in absence or erosion of the small little labyrinthine bones here involved in the mastoid air cells, then this is radiologically what we can refer to as coalescent mastoiditis. Now, just realize that mastoiditis is not a radiological diagnosis. It is a clinical diagnosis that is made by pain over the mastoid air cells and also pain on palpation, tenderness on palpation. So if you see something like this, what the best way to say it is that the imaging findings are consistent with the clinical diagnosis of mastoiditis. And when you see absence of the bone, then this is what we refer to as coalescent mastoiditis. And when we look at the coronal images, again, we can see absence of the bone. Now, if you have a skull base infection that begins to extend medially and involves the petrous apex, then you have to start worrying about infections involving the petrous apex, and that's referred to as petrous apicitis. Now, the classic thing that we're always taught is the syndrome of Grad-Nago syndrome, and this was described in the early 1920s or 30s by Giuseppe Grad-Nago. And what Giuseppe Grad-Nago described, and again, this was long before the days of CT and MR, but what he described was a patient that ended up having a skull base infection that had the clinical findings of retrobulbar pain, a 6th nerve palsy, and otitis media. And remember, back then, they don't have the aid of MR and CT. So if a patient had otitis media, 6th nerve palsy, and retrobulbar pain, this is what was referred to as Grad-Nago syndrome. And the reason why these patients ended up having a 6th nerve palsy is because the 6th cranial nerve exits the pons at the pontomedullary junction. It then extends anteriorly in the prepontine cistern and then extends to a small little canal right here, which is Dural's canal. So in this case, we have an abscess involving the petrous apex, and it could extend medially to involve the region of the Dural's canal, which is between the petroclival fissure, and that would affect both the 5th and the 6th nerve, and that's why these patients developed the 6th nerve palsy. Another complication that we always have to worry about when we're looking at infections involving the middle ear and the mastoid ear cells is that they can extend posteriorly to erode the cortex right here and erode the dural plate. And if this continues, then this can result in dural sinus thrombosis. So dural sinus thrombosis is a complication of middle ear and the mastoid infections. The symptoms are otalgia, headaches, and nausea and vomiting. And what has been described were dural sinus thrombosis, and quite frankly, I've never seen it, but it's this sign referred to as Greisinger's sign, which is edema and tenderness over the mastoid process. Now, you can either do CTV or MRV. I personally like CTV because it's quick and I'm looking at positive contrast. I know sometimes on MRV, it can be a little bit confusing to look at some of the slower flow and try to differentiate whether there's clot versus flow void. Obviously, one thing that's beneficial about MR is that if you are worried about a venous infarction, this can be better seen using diffusion-weighted imaging. Now, if this mastoid infection extends inferiorly and erodes the distal portion of the mastoid tip, then this can result in what we refer to as Biesel's abscess. And again, this is described years ago, back in at the turn of the century, by Frederick Biesel, who was a German pathologist. And what Beazell described was Beazell's abscess, again, was a complication of acute mastoiditis. And this is classically identified as erosion of the mastoid cortex and involves the sternocleidomastoid muscles. Now, the one nice thing about a classic Beazell's abscess is that they are decreasing in incidence, obviously because of the early use of antibiotic therapy, but in a way the definition has expanded. So when Beazell described this, he described erosion of the inferior portion of the mastoid tip with an abscess extending along the sternocleidomastoid muscle. But oftentimes when you go to meetings, sometimes this will be described as a Beazell's abscess. And what this is diffuse phlegmon and a diffuse soft tissue overlying the mastoid tip. So in a way, it's almost like that Pott's puffy tumor that's overlying the frontal sinus. So in a way, it's somewhat similar to this, but this is sometimes described as Beazell's abscess. So this diffuse phlegmon overlying the right mastoid, an infected right mastoid air cells. Now, finally, what can happen is that if you have severe infections involving the mastoid air cells, this can result in a variety of intracranial complications. So this is an example of cerebritis. Here we can see abnormal enhancement involving the inferior portion of the right temporal lobe. Remember, the inferior portion of the right temporal lobe directly abuts the tegmen mastoidium. So anytime that you have a severe middle ear infection, it can extend superiorly into the inferior portion of the temporal lobe, giving you the complication of cerebritis. And if this goes on to continue, you can go ahead and develop a frank intracranial abscess. So this is an example of an intracranial abscess. Here we see more of the classic ring enhancement around this abscess. And when we look at the T2 weighted images, we can see the associated vasogenic edema. So in summary, what I've done during my time is that I've talked about infections involving the neck and infections involving the skull base. These are all common things that you may see in the middle of the night. And I hope this talk will help you better make these diagnoses and provide overall better patient care. Thank you very much for your attention.